Good morning, wherever you're in the world, and early morning in Canada. My name is Dr. Alison Fox-Robichaud. I'm a critical care physician at McMaster University, and I'm welcoming you to this second session of the second World Sepsis Congress. Specifically, this time we're focusing on antimicrobial therapy and source control. Our first speaker today is Professor Matthias Pletz, who's Professor of Infectious Diseases at Jena, and he will be speaking on improving outcome for Staphylococcus sepsis. I'll remind the audience that you have a public chat at which you can ask questions, and we will select 2 or 3 at the end of Professor Pletz's talk.
Okay. So, dear audience, I want to convince you that Staph aureus bacteremia, briefly SAB, is a distinct entity that requires an aggressive treatment. And I want to make you familiar with the key concepts of this treatment. So, SAB has a high burden of disease. It is very frequent. So, in our 1,400-bed university hospital, we detect about 250 to 300 patients a year. It has a high mortality despite antibiotics, that is between 15 to 30%. And it has a high rate of complications, namely secondary foci in 30 to 40% and up to 10% relapses. Secondary foci are the main problem in Staph aureus bacteremia. 1 in 10 patients will develop endocarditis, 5% will develop septic arthritis or spondylolisthesis, but the highest risk bear patients with intracardial devices or prosthetic hips. They have a risk of 30 to 40% to develop foreign body infection during Staph aureus bacteremia. So what are the key concepts? And there is a nice Spanish study. The authors first did an intensive literature review, and then they came up with 6 quality of care indicators proven to decrease the mortality in Staph aureus bacteremia. And then they implemented those 6 quality of care indicators as a bundle in 12 Spanish hospitals, and they did a before and after analysis and found a decrease in 14-day mortality from 18 to 11%. That's almost halving mortality. And the bundle was an independent predictor of survival in the study. So what were the individual quality of care indicators? First, follow-up blood cultures. By the way, if you detect Staph aureus in a single blood culture, it's always an infection. It always needs to be treated. But in Staph aureus bacteremia, you should repeat those blood cultures after 48 to 96 hours. If they are still positive, despite antibiotic treatment, this is a strong hint towards an endovascular infection or early treatment failure. Second, early source control. More than half of hospital-acquired Staph aureus bacteremia is caused by infected vascular catheters. They need to be removed immediately. If you have an abscess, it should be drained within 72 hours, and if you suspect an infected foreign body, like a prosthetic joint, it should be removed within 72 hours. Third, echocardiography. I told you 1 in 10 patients will develop endocarditis, particularly patients with community-acquired Staph aureus bacteremia, because it usually lasts longer until it is detected, patients with intracardial devices, and patients with positive follow-up blood cultures are at increased risk and need a TEE to exclude endocarditis. The fourth point is sometimes not known by clinicians. This is early use of intravenous cloxacillin or any other anti-staphylococcal penicillins. That is flucloxacillin, decloxacillin, or nafcillin, for instance, as definite treatment for methicillin-susceptible Staph aureus. The only alternative is cefazolin, a cephalosporin of the first generation. And this is something tricky because MSSA is susceptible to all beta-lactams in vitro. So you will get an antimicrobial susceptibility testing telling you all beta-lactams work. However, in the patient, you have an increased mortality if you use any other antibiotics except anti-staphylococcal penicillins or cefazolin. And there are numerous retrospective and prospective cohort studies that have shown that, for instance, with cefuroxime, mortality is doubled, and the same holds true for ceftriaxone or piptazo, for instance. The open remaining question, current matter of debate, is what is better, cefazolin or flucloxacillin? And cefazolin has the advantage that it's much less hepatonephrotoxic compared to the anti-staphylococcal penicillins, but it has the disadvantage of decreased brain penetration, so it's no option for brain abscesses, and it is susceptible to the so-called inoculum effect. What's meant by that? If you have a high bacterial load, those Staph aureus will produce a high amount of beta-lactamase, and cefazolin is not that stable against this beta-lactamase like the anti-staphylococcal penicillins. However, many retrospective studies, like this US study, have shown that in the end of the day, you have a decreased mortality when you use cefazolin. In this study, it was decreased by about 1/3. And there are two recent meta-analyses that confirm these results, saying that you have a lower mortality if you use cefazolin instead anti-staphylococcal penicillins. A randomized controlled trial is underway, but not yet finished, but I believe that cefazolin becomes the first choice in Staph aureus bacteremia. Fifth, if you have an MRSA bacteremia, you should use vancomycin according to trough levels, and the trough levels should be between 15 to 20 milligram per liter, not 5 to 10 like in the old textbooks. And finally, treatment duration. We all want to treat shorter to save antibiotics. However, there are important exceptions, and Staph aureus bacteremia is one of them. You need to treat SAB at least for 14 days IV if it's uncomplicated, and 28 days up to 6 weeks if it is complicated. So what's the definition of uncomplicated versus complicated? According to the IDSA, uncomplicated means exclusion of endocarditis, no implanted prosthesis, follow-up blood cultures are negative, the fever is sensed within 3 days, and no evidence of metastatic sites. Then 14 days IV is sufficient. If one of those parameters is not fulfilled, you need 4 to 6 week treatments. An open question is when it is safe to switch to oral treatment. In endocarditis, never. But in osteomyelitis, for instance, our standard switches after 2 to 3 weeks. So how can we bring this bundle to the patient bed? And there's a meta-analysis that showed that if you involve infectious disease physicians, you can decrease mortality by 40% and relapse rate by 30%. And our center, for instance, started unsolicited SAB consultations 4 years ago, and we recently published the first 300 cases, and we found exactly the same numbers as in the Spanish study I've shown you. We could decrease mortality by from 23 to 11%. This was highly significant. And even in the multivariate analysis, controlling for severity and comorbidity, ID consultations had an odds ratio of 0.42 for mortality. This responded to a number to treat of 8. That means every day, every 8 ID consultations in SAB, you can save 1 life. And we even saw a dose-response relation, because if all of our recommendations were executed by the treating physician, we saw a decrease to 11%. If not all of our recommendations were executed, we saw a decrease of mortality only to 18%. And this is the reason because the Surviving Sepsis campaign in its 2016 guidelines states that early involvement of infectious disease specialists can improve outcome in Staph aureus bacteremia. So to sum up, I've shown you that Staph aureus bacteremia, and this holds true for both MSSA and MRSA, is a distinct entity requiring an aggressive approach, consisting of, first, take every Staph aureus in blood culture serious and perform follow-up blood cultures. Positive follow-up blood cultures may be a hint towards early treatment failure and endovascular infection like endocarditis. Second, identification and control of the source. This means particularly a transesophageal echocardiography in patients at risk. Third, anti-staphylococcal penicillin or cefazolin for methicillin-susceptible Staph aureus bacteremia, and vancomycin trough levels between 15 to 20 milligram per liter in MR-SAB. Treatment duration should be at least 14 days IV for uncomplicated and 4 to 6 weeks for complicated SAB. And there are studies showing that unsolicited ID consultation can decrease mortality. Thank you very much.
Thank you very much, Professor Pletz. We have one question from the audience in terms of penicillin allergies, and you may want to get into the cefazolin use in penicillin allergies.
I believe cefazolin is mostly safe in penicillin allergy because the most frequent penicillin allergy is amoxicillin allergy, and this is T-cell dependent, and it's actually a rush, not a septic shock. However, if the patient reports allergic shock, if the patient reports symptoms of an allergic shock, you must use another treatment. For instance, daptomycin is also very effective in killing bacteria at metastatic sites, except the lung. But if it's just the rush caused by amoxicillin, cefazolin is safe.
There's a second question about the use of ampicillin sulfobactam as a first line for Staphylococcus aureus infections.
The same holds true for Piptazo. If you use this drug, you will see an increased mortality despite proven in vitro susceptibility.
Okay. And then one final question. When using cloxacillin, is there a rationale for Q4H versus Q6H dosing?
Yeah, as for all beta-lactams, the time above MIC is the best predictor of clinical success. And if you do this more frequently, you will increase the time above MIC, and you will probably see a better clinical response. However, prospective clinical data on this issue are lacking.
Okay. Thank you very much, Professor. We'll move on to our next speaker.
My pleasure.
Our next speaker this morning is Professor Jean Chastre. He's Professor of Medicine at the University School of Paris, and we're going to move on to talking about inhaled antimicrobials. Do they play a role in sepsis?
Okay, so thank you, Alison, for the introduction. Good afternoon to everybody, and I will start immediately for the sake of time, of course. I put my disclosure on the first slide. And as you know, probably very well, but very unfortunately, pneumonia in the ICU remains a common complication and leading to sepsis and septic shock in many patients, particularly, of course, when the infection is caused by a very difficult to treat microorganisms, for example, Pseudomonas aeruginosa or Acinetobacter. In that case, even using a regimen combining two drugs for a long period of time, even in that case, the survival is not very good and stays below 60%. There are probably two factors that might explain these suboptimal results. First, we are now facing a lot of infection caused by resistant or poorly susceptible microorganisms, and therefore it's much more difficult to treat those infections. And secondly, the penetration of most antibiotics into the lung tissue is not very good, rendering difficult to reach the PK/PD targets requested for a maximal bacterial killing. Most of the time, the penetration of beta-lactam into the lung is below 30%. And therefore, directly delivering antibiotics to the lung via aerosolization may increase the drug concentration at the infected site, and this is a key issue. And of course, also, by limiting the systemic exposure, it could also decrease the high systemic toxicity we could observe with some antibiotics, for example, amikacin or polymyxin. But this is not so easy, in fact, to do that. And there are a lot of factors that can influence the nebulization efficiency, including the size of the particle. This is probably one of the major factors. The type of the generator used for the aerosolization, the ventilator circuit, the ventilator settings, and of course also the type and the severity of the lung lesions. Probably, as I said before, one of the most important parameters driving the deposition of the drug in the airways is the size of the droplet with an optimal diameter of 1 to 3 micrometer. If the size is above that, the deposition is mainly in the proximal airways. And if the size of the droplets are below 1, most of the time the droplets are directly exhaled with the expiratory gases. So the size of the droplet is really the key factor. It's possible to use 3 types of devices. The first one is using a jet nebulizer, the second one using an ultrasonic nebulizer, but probably the best one would be to use a vibrating mesh nebulizer. There are 2 potential major advantages for using that type of generator. First of all, the droplet size is very small and very well calibrated. And secondly, and this is important for some antibiotics at least, the antibiotic solution is not heated. We have now very strong data showing that using those devices, it's possible to deliver more than 40% of the dose to the deep compartment of the lung, with very high concentration in tracheal aspirate, as well as in the epithelial lining fluid. So really, it's now possible to target the deep compartment of the lung. Interestingly, and as expected, using antibiotic nebulization, the systemic exposure to the drug is very limited. And this is also a major advantage of such technique because it allows to use a potentially nephrotoxic drug such as amikacin or colistin. Of course, even using the best device, there are a number of key practice recommendations to respect. First, the humidifier should be removed from the ventilator circuit during the nebulization process. Otherwise, the size of the droplet would increase and therefore the penetration of the drug into the tracheobronchial tree will be limited. Secondly, and this is very important for safety reason, the filter protecting the ventilator at the end of the expiratory circuit should be removed after each nebulization to avoid the clogging and therefore the obstruction of the ventilator circuit. This is a very dreadful complication that could lead to cardiac arrest, of course. So this is very important. We have now pretty good results showing that, at least in experimental animal models and data obtained in a small number of ICU patients, that it's possible to reach a very good concentration of the drug into the tracheobronchial tree. For example, in that study conducted in ventilated piglets, so a big animal model infected with Pseudomonas aeruginosa, in that study, it was possible to sterilize the lung tissue using only nebulized colistin. And interestingly, doing that, the results were better compared to those obtained with IV colistin. But as you know, the penetration of IV colistin into the lung is very poor. We have also some phase 2 studies conducted in ICU patients with ventilator-associated pneumonia that have also confirmed the clinical relevance of that mode of administration. But we should be very careful, in fact, because when all those phase 2 studies, most of them purely observational and not really double-blinded control, in those studies, when they were all reviewed, systematically reviewed and meta-analyzed, a very small clinical benefit could be documented, and only regarding the clinical resolution rate, and only in observational study, not anymore when the study was randomized and controlled double-blinded. And this is, as you can imagine, a major limitation for the moment. And as shown on the next slide, and as you can see, no significant improvement in clinically important outcome, such as mortality or duration of mechanical ventilation, could be demonstrated even in observational study. And more vexing, maybe, we got very recently the results of two double-blinded placebo-controlled randomized trials. And those two studies, the first one assessing the potential benefit of phosphomycin plus amikacin in comparison with IV best conventional therapy. In that study, no benefit at all could be demonstrated, as you can see. Also, in a multinational randomized placebo-controlled double-blinded study assessing the potential benefit of adjunctive therapy with amikacin compared to and using very good technology for making the nebulization using a mesh vibrating nebulizer synchronized with inspiration, but even doing that, no benefit at all regarding the primary endpoint, which was in that study overall mortality at day 28, but also, and this is also very important to note, all the secondary endpoints, including adjudicated pneumonia-related mortality, early clinical response, duration of mechanical ventilation, or the number of ICU days, exactly the same results in the two treatment arms. So no benefit at all in the very large study, very well conducted, using a very good technology. It was not possible to show anything. And therefore, based on that, the only very good results we have are limited to patients infected with very difficult to treat a microorganism. For example, in patients infected in the ICU with a colistin only susceptible gram-negative bacillus. In that case, we have pretty good data, not very strong, but pretty good data showing that using colistin as an adjunctive therapy by nebulization to best conventional IV therapy, in that study, pretty well controlled, not randomized, but the investigators control most of the potential confounder. And as you can see, the duration of mechanical ventilation was shorter in patients randomized, not randomized, but treated with colistin by nebulization in conjunction with IV colistin. So a real benefit in patients infected by very difficult to treat gram-negative bacillus. And therefore, based on that data, most of the recent guidelines, including those published by the ETS and the IDSA societies, recommend to restrict the use of nebulized antibiotics to patients infected with gram-negative bacillus only susceptible to colistin or to amikacin in combination with the use of the same antibiotics IV. So very limited indication for the moment. But of course, maybe we will reconsider the possibility of increasing the potential indication of the drug based on additional data. We will see. Maybe it could be of some interest for using ventilator-associated tracheobronchitis in patients with ventilator-associated bronchitis as a preemptive therapy, maybe, or to prevent the emergence of resistance. In fact, we have some limited data showing that using nebulized antibiotics, it's possible to prevent the emergence of resistance. But those data are very limited, and therefore we need to be very careful. So thanks a lot for your attention. And if you have some question, I can maybe try to answer.
Thank you, Professor Chastre. Very interesting topic. We do have a few questions for you. The first, you've really focused on the role of colistin. Do you have any historical evidence around other antibiotics and which particular pathogens? You mentioned 3, but there would be a specific criteria in addition that would be specific for using inhaled antibiotics?
Yes, this is a very good question, of course. Yes, most of the data we have in patients infected by very difficult to treat microorganisms were obtained in patients infected by Acinetobacter baumannii, or in some study infected by Pseudomonas aeruginosa, very resistant to antibiotics. So this is a very small fraction of patients infected by Pseudomonas aeruginosa, for example. And you know, for example, in patients infected by a carbapenemase producing gram-negative bacillus, in that case, we have maybe some alternative. But if it's not the case, it could be also possible to use nebulized colistin or amikacin, maybe, or phosphomycin, maybe.
Okay. Is there any dosing difference or dilutional considerations for the preparations that should be nebulized?
Yeah, this is also a very good question, because, you know, it's not possible. You need to use a very specific formulation using nebulization. So we have only 2 or 3 drugs for which we have enough data to recommend their use. For example, tobramycin or amikacin. But you need to use a specific formulation, pH control, with no additive particularly. Otherwise, you could observe a lot of bronchospasm or other complications. So the formulation of the drug is also a key issue. And unfortunately, we have only limited data. So the technology is important. The way you are doing the nebulization is also important, as well as the formulation, the specific formulation you are using.
And the final question, any comments about the dosing of colistin nebulized? And
yes.
Is there any consideration when patients
also
are in renal failure?
It's also a very important consideration, because, as you know, the pharmacokinetic of colistin is not very well known, in fact. So probably we need to use a larger dose than the dose that were initially recommended. So probably at least 2 million international units Q8 hours. So pretty big dose using that drug by nebulization.
Okay. Again, thank you very much, Professor Chastre. We're going to move on to our next presentation. Our next speaker is Professor Tobias Welte from Hanover University, where he is Professor of Pulmonary Medicine, and he's going to speak about novel antibiotics to overcome resistance.
Yeah, hello, my name is Tobias Welte from Hanover in Germany, and I want to give you a quick overview what is new in the pipeline of antibiotics. One of the major problems we have in our days is that there is an increase in resistance development, which has been on gram-positives 50 years ago, directly after the introduction of the first antibiotics, for example, penicillin. But now it's more a problem on gram-negatives, and there's only one gram-positive pathogen, which is Enterococcus faecium, which is still a problem. However, there are other gram-negatives like E. coli, Klebsiella, Pseudomonas, and Acinetobacter, which are very hard to treat in our days and which need new antibiotics. One of the major problems in our days is that antibiotics has been used in veterinary medicine for a long time and in high dosages, mainly in the Asian countries, but also in Africa and South America. which creates new resistance genes, for example, the WIM and IMP genes, which make antibiotics not successful, not efficient in most of the cases. Therefore, the IDSA, the American Society of Infectious Disease, has announced a Bad Bugs Need Drugs initiative years ago with the hope to have 10 new antibiotics on the market in between the next 10 years. And I will show you that this, in some circumstances, has been successful. There are some problems which make it difficult to develop new antibiotics, mainly regulatory purposes, so to run two parallel trials with a high number of patients to show an efficiency of a new antibiotic is hard to make and very expensive, and we all are in discussion with the regulatory authorities to get it easier to develop antibiotics in the future. So let's come up with the current standing in terms of resistance. First, gram-positives. There is worldwide no problem with streptococci. Most of the streptococci available are not resistant against the antibiotics used, and even in the case of resistance, if there is high dosage, you overcome the resistance mechanism. MRSA had been one of the major problems in the past 10 years. However, due to better hygiene measures and a better infection control policy, MRSA now is decreasing. The rate is decreasing worldwide. In my country, in Germany, we started with 25% MRSA rate in 2010, and we are now down 15%, and we will come down to about 10% in the next years. Looking to the antibiotics which are available on the gram-positive side, there are a huge number of antibiotics which could be used for different sites of sepsis origin, starting with the glycopeptides and euglycopeptides, and then we have daptomycin, we have tigecycline, we have other new oxazolidinones and new kinds of tetracyclines which are effective in different circumstances. And I only want to show you a study comparing tetisolide, a new more bactericidal oxazolidinone with linezolide in susceptible and resistant Staph aureus infections, and it's a very effective drug. So I'm not concerned about what's happening on the gram-positive side. On the other hand side, we have the gram-negatives, the Enterobacteriaceae and the non-fermenters, mainly Pseudomonas and Acinetobacter. And for all this, resistance development had increased during the last decade, and it is still increasing. In some countries, mainly in Southern Europe, but also in Asia, South America, and Africa, the rate of carbapenem-resistant Enterobacteriaceae is up to more than 80%, and multi-drug-resistant Pseudomonas are up to 90%. Nevertheless, there are a number of new drugs to treat pneumonia, but also sepsis for gram-negative infection, which had been launched, like ceftolozane tazobactam or ceftazidime avibactam, or which are in phase 2 and phase 3 trials at the moment. And I only want to show you the ones which had been launched during the last year or the last 2 years. I do not get the next slide. I will tell you without it. So, ceftolozane tazobactam had been tested in patients with urinary tract infections and also with intra-abdominal infections, and it had been shown to be as effective as the main comparator, which had been carbapenem or piperacillin tazobactam on the other hand side. We are waiting for the ceftolozane tazobactam study. Here are now the results for the intra-abdominal and the UTI trials. We are waiting for the ceftolozane trial in pneumonia, and this is a very important trial because in this circumstance, ceftolozane has been dosed double, and in my mind, this is a right dosage, a doubling of the dosage which had been used in the UTI trials. However, the study results are not available. The second drug is ceftazidime avibactam. Avibactam is a new beta-lactamase inhibitor, which is also effective against group D beta-lactamases, mainly oxa beta-lactamases, and CATS-AVI had been studied also in UTI and intra-abdominal infection, but, and this is very important, also in nosocomial and ventilator-associated pneumonia. In all these trials, the same dosage had been used and the same comparator had been used, which had been carbapenem, imipenem, or meropenem. To make a long story short, in all these trials, CATS-AVI demonstrated a similar efficiency in comparison to the comparator, to the carbapenem, and for the first time it had been shown that a new antibiotic is as effective as an older one. One of the main advantages of the CATS-AVI studies had been that there had been shown that also for strains who are ceftazidime resistant, using the new inhibitor, the avibactam, makes it a susceptible drug with a high efficiency. And as you can see here, these are the pneumonia results demonstrating a similarity between CATS-AVI and the meropenem. There are other beta-lactamase inhibitors which are now in clinical studies, which will broaden the spectrum of the antibiotics, not only to class D beta-lactamases, but also to class C beta-lactamases, and finally, which will give us a better chance to overcome antibiotic resistance. And these are my last slides. This is the first paper about one of the other inhibitors, which is vabobactam, in combination with a carbapenem, demonstrating a superiority in patients with pan-resistant infection, pan-resistant UTI infection. To summarize, altogether, the initiative by the IDSA to develop more antibiotics, mainly on the gram-negative side, had been successful. There are new drugs available. However, the speed of resistance development is as fast as the speed of antibiotic development. So we have to hold on with our work, with our initiatives. And on the other hand side, we have to set up better international consortia to allow to set up a network to do trials in multi-drug resistant infection to make it faster, more effective, and more successful to develop new antibiotics. Thank you very much for your attention.
Thank you very much, Professor Welte. I have one question for you, just in the interest of time. There was one figure where you showed among the gram-positives that the enterococcus resistance was actually increasing. Yep. And I know in our center, VRE is a particular problem. Is there any drugs coming down the pipeline from that end?
Yeah, two very short comments. First, VRE is increasing, and what is a little bit concerning is we do not know why. Because it has nothing to do with glycopeptide use. So there is a development of resistance. We are not aware why it takes place, which makes it a little bit difficult. The second answer is yes. Some of the new antibiotics, mainly the new tetracyclines, like omadacycline or efracycline, are effective against VRE and could overcome the problem. And there is a second possibility. Most of the MRSA drugs have not tested for VRE, but they may be successful. So this is something we have to do, for example, to look to data for daptomycin in VRE or for other glycopeptides in VRE to get a better possibility.
Okay. Thank you very much, Professor Welte. We, in the interest of time, we'll keep ourselves on schedule and move on to our next speaker.
Thank you.
Thank you. Our next speaker is Professor Charles Gomersall from the Department of Anesthesia, Chinese University of Hong Kong, and Professor Gomersall is going to speak specifically about sources, finding the source of sepsis. Challenge for us all.
Alison, thank you very much. And thank you to the organizers for inviting me to speak. I'm going to give a very simple clinician's guide to finding the source of sepsis over the next 10 minutes. So I'll start with why does it matter? Well, probably the most important reason is to identify any source that is amenable to source control measures. As we know, early source control is important. So identifying the cause is an urgent priority. Furthermore, the source may give us clues to the organism, as well as being important in prognosis and predicting the clinical course. Now, in order to illustrate some of the points I want to make in this lecture, I want to tell you about a case that was recently admitted to my ICU. She was a 35-year-old woman who worked as a domestic helper in a rural area of Hong Kong. And yes, I know it's hard to imagine there are rural areas in Hong Kong, but there really are. She presented to the emergency department with fever, chills, and a 2-centimeter diameter submandibular swelling that she said had started as an insect bite. On examination, she had associated lymphadenopathy, and the emergency department doctor made a diagnosis of an infected insect bite. However, when she was seen on the ward, the doctor there thought it was an infected sebaceous cyst and treated her with amoxicillin clavulanate. Over the next few days, she developed acute respiratory failure, liver dysfunction, coagulopathy, and shock, and had clearly progressed from infection to sepsis, and at that point, she was referred to us. We resuscitated her and simultaneously started on finding the source of sepsis. So, how do we go about this? The symptoms and signs will obviously give important clues. However, it's important to realize they may be confounded by the clinical features of sepsis. Furthermore, clinical features may be misleading in the elderly, the immunocompromised, and in children. Now, fortunately, our patient did not have overt encephalopathy, and we were able to take a history as well as examine her. Importantly, she was able to tell us that the submandibular lesion started as an insect bite, a piece of history that had been buried after admission to hospital. This was supported by the appearance of the lesion, which I will describe to you later. Now, apart from signs and symptoms, the other really important clues come from the epidemiology of sepsis. Data which is shown in Bert Tillman and Hannah Wunsch's recent review of the epidemiology confirms that what we, I think, all know clinically, the commonest site of infection is pulmonary, followed by intra-abdominal and urinary tract. So we would consider a chest X-ray to be a standard part of investigating a patient with sepsis. This was the chest X-ray shortly after presentation to hospital, and you can see it really does not suggest pneumonia as the cause of her original infection. The question then is this a reliable screening tool to exclude pneumonia? Pooled data from 5 studies suggests that the sensitivity of a chest X-ray for the diagnosis of pneumonia is only about 77%, although the specificity is reasonable at about 91%. But it's important not to use these data in isolation. In this patient who had no respiratory symptoms or signs on presentation, the probability of pneumonia was low, so we were reasonably reassured by the normal chest X-ray and felt community-acquired pneumonia was unlikely. Interestingly, and I apologize for those who don't get to see the slide, if you look at the right-hand panels, the left-hand panels show the results. I'm getting confused. The left-hand panels show the results for ultrasound, and you can see that ultrasound has a considerably higher sensitivity at about 95%, with a similar specificity to X-ray, suggesting that lung ultrasound might be a better initial investigation. However, by the time we saw the patient, her chest X-ray had deteriorated markedly, and although we believe this was likely to represent lung injury secondary to sepsis, it clearly was not possible to exclude the possibility of a nosocomial pneumonia. So we think of the second most common cause, intra-abdominal infection. The diagnosis of intra-abdominal sources of sepsis is based on clinical examination, ultrasound, and CT. Our patient had a soft abdomen with no tenderness, organomegaly, or jaundice. She had already had an ultrasound of her hepatobiliary system, which was normal, and dipstick testing of her urine was negative for leukocytes and nitrites. Again, we have this question of, is the dipstick testing a reliable method of excluding the possibility of urosepsis? The results are variable. So the greatest sensitivity comes if you use a positive test for leukocytes or nitrite as an indicator of urinary tract infection. But even using this either-or approach, the sensitivity of dipstick testing ranges from approximately 65% to 80%. And the sensitivity of dipstick testing for diagnosing Chastre-associated urinary tract infection is equally poor. As a result, because our patient also complained of dysuria, we performed a contrast CT of her abdomen and pelvis to exclude the possibility of pyelonephrosis or other intra-abdominal pathology. And her CT was normal. Now, our patient didn't have a central line, but I just want to touch briefly on central venous catheter-related infection and point out that the sensitivity of differential time to positive blood cultures is actually only 80% for short-term catheters. And This is even if you sample all the lumens. The sensitivity, not surprisingly, is lower if you actually only sample one lumen. So what if there's no obvious focus? What differentials should you be thinking about? Now that depends a lot on risk factors in your patient or in your geographical area. But in my practice, I'd be thinking about toxic shock syndromes, invasive candidiasis, dengue, malaria, leptospirosis, brucellosis, Q fever, and rickettsial diseases. Which takes us back to our patient's submandibular lesion. This was a 2-centimeter oval lesion with a raised erythematous edge and a necrotic center. And for those of you not familiar with scrub typhus or typhus, this is the typical appearance of an eschar associated with a tick or a mite bite. And this is where the fact that she lives in a rural area comes in, because it's only in one particular rural area in Hong Kong that mite bites occur. And so this led us to the clinical diagnosis of scrub typhus, which was subsequently confirmed by serology. However, we didn't think we could exclude the possibility of nosocomial pneumonia, so she was also treated for that. So, in summary, for the majority of patients, finding the source of sepsis depends on the history and examination. An investigation should largely be guided by clinical features and the epidemiology of sepsis. And this means that most patients, you're going to be thinking about pneumonia, thinking about intra-abdominal infection, and urinary tract infection. And the investigations are targeted initially primarily to those three areas. It's important that you understand the sensitivity and specificity of these investigations and interpret the results in the context of the prior probability. Thank you very much.
Thank you, Professor Gomersall. We actually have a question from a young high school student in the USA who's asking about finding the source of sepsis in bariatric patients. Wondering if you've got any pearls of wisdom.
Well, I have to say, not a huge experience in Hong Kong. Chinese are not generally very big. So if you're more than about 60 kilos as a woman, you get labeled as obese, but doesn't really cause a lot of problems. So my experience is pretty limited. In very large patients, it's extraordinarily difficult. Even CT, the CT scan tables have a weight limit of about 220 kilos. And so if you're above that, it's hard to do a CT. My only experience of a very large patient is when we tried to do it, we couldn't do a CT, we couldn't do an ultrasound. We did an ultrasound, the radiologist told us there was a liver. So I think that it's an extraordinarily difficult group to treat. But one then is left with, I think, clinical examination, which again is difficult, and then treating with very broad spectrum antibiotics, because the source is generally unclear, and this is what we did in that patient. We couldn't scan, and we couldn't CT scan, and we couldn't usefully ultrasound. I know that doesn't really answer your question, but... No,
but it certainly does present the challenges with the obese patient in terms of determining the source of sepsis. Second question is somewhat related to that. You talked briefly about the value of ultrasound in pneumonia. I'm wondering, in that undifferentiated infection, whether you have any value on using things like white cell scans to identify potential focus for infection.
For radionuclide white cell scans, my experience is you get so many hotspots, it really doesn't help you in critically ill patients. We have very limited access to PET-CT, so I have almost no experience of that. But the radionuclide scans I have never found to be of any value.
And the final question has to do with the patients on chemotherapy and where you think the most common source of sepsis is for those patients. I have an idea, but...
Yeah, I think there's the two main areas, really. Again, chest and intra-abdominal. But with the intra-abdominal infection, I think it's not really the source. I think is the abdomen, but it's not necessarily a perforation. So I know the experimental or the human evidence for translocation is actually not very good. But I think the immunocompromised patients are a group where it's much more likely that is a genuine cause of bacteremia, but it's not a source in the sense that you need to go and drain it or cut it out.
Well, that's a perfect segue into our next speaker. Thank you again for Professor Gomersall, and we will move on to our next.
Thank you. Bye.
Thank you. So it's a great pleasure to introduce our next speaker, my colleague and friend from Canada, Professor John Marshall, who's Professor of Surgery and Critical Care at the University of Toronto, who's going to talk about the surgical source control.
Terrific. Well, thank you very much, Alison, and thank you, Professor Gomersall. You've made a very nice segue into the talk that I'm going to be giving. I'm going to be speaking about source control. I've put surgical in brackets because increasingly we can accomplish this goal with techniques other than surgery. But I do want to emphasize that along with antibiotics, it is one of the two effective things that we can do to treat the infections that cause sepsis. And probably it's an area that we haven't given as much attention to as we might. So what do I mean by source control? We can define it as all those physical measures that are undertaken to eradicate a focus of invasive infection, to correct the anatomic derangements that are responsible for ongoing microbial contamination. So some infections cannot be cured without source control. If you're looking at a necrotizing soft tissue infection or dead bowel or perforation of abdominal viscus, their source control is absolutely essential for successful management, and antibiotics alone are going to be unsuccessful. There are, of course, other infections that are not readily amenable to source control. Pneumonia, for example, bacteremia is another example, although there are, in fact, circumstances where both may render themselves susceptible to source control. For example, if a bacteremia is secondary to a colonized line, then removal of the line may be sufficient to treat the infection. Similarly, if pneumonia is complicated by an empyema, drainage of the empyema and possible decortication of the lung is a key part of successful management of the infection. So when is source control indicated? First and foremost, when there is a focal infectious process. The concept depends on the fact that one can convert a localized infection and control it by one of several principles, which I'll outline on my next slide. If the infection arises from the breach of a whole organ, such as the gastrointestinal tract, the esophagus, the biliary tract, source control is indicated. Clearly, when there's tissue necrosis, antibiotics can't enter necrotic tissue, and source control is critical in the face of tissue necrosis. And finally, when infection arises in relationship to a foreign body, and I'll discuss that in more detail a little bit later. So the principles of source control are very much principles of surgery, and they can really be summarized in 4 Ds. Drainage, which converts a liquid infection to an external collection. Debridement, which is the removal of infected solid tissue, device removal, which is self-explanatory, and critical for the patient is the conversion to a normal state of health after the infection has been dealt with. So the definitive repair of an abnormality, an anatomic abnormality, and the restoration of normal anatomy is critical to the principles of source control. So what is drainage? In essence, what drainage does is it converts a closed space infection into a controlled sinus or fistula. So here on this slide, you can see a liver in the abscess, or an abscess in the liver. It is characterized by a capsule surrounding a collection of bacteria, neutrophils, and liquid debris. And placing a drain into that will create a communication between the internal portion of the liver and the outside and effectively resolve that infection. On the lower part of the screen, you can see a CT scan of a patient with diffuse peritonitis. Unfortunately, there's no simple way with percutaneous drainage that can be controlled. So just to summarize then, drainage creates a controlled sinus, which is a communication between a closed space and an external surface, or a fistula, which is a communication between two epithelially lined surfaces. And drainage is appropriate for any infection that has a significant liquid component to it. Increasingly, we're accomplishing this objective using percutaneous techniques, such as are shown here, using a percutaneous drain that is placed under image guidance, and the drain is passed along a guide wire using a Seldinger technique. And the beauty of this particular approach is that it causes much less disruption to surrounding anatomy and much less physiologic disruption to the patient. And therefore, you can drain, for example, a diverticular abscess percutaneously and subsequently undertake a resection of that involved portion of the sigmoid colon as a single-stage operation. This is something that in the past we used to do in 2 or even 3 sources of operation. Now, most cases of abscesses can be drained percutaneously, but surgery is necessary if it is not possible to create a controlled fistula. And typically the reason for that is that the infection itself is not walled off. So a patient with diffuse peritonitis is not sufficiently walled off. If there is dead tissue in association with it, surgery is going to be necessary. And that surgery typically will involve, in the gastrointestinal tract, the creation of a stoma, which in itself is a controlled fistula to maintain adequate source control. Increasingly in complex infections where local control can't be gained by catheter drainage, we are using more radical techniques such as an open abdomen type approach, which really converts the entire peritoneal cavity into an open fistula. This has the advantage of gaining adequate source control, the disadvantage of requiring multiple reconstructive procedures to get the patient back to a normal state of health. But in complex infections with poor localization, it can be life-saving. The next principle in source control is debridement, which can be defined as the physical removal of necrotic or infected solid tissue. And this can be done through several different modalities. It can be accomplished surgically. It can be accomplished with dressing changes, which is done in open surgical wounds. And it can be accomplished through the use of debriding agents. So here are some examples of infections that require debridement for successful management: necrotizing soft tissue infections and bowel ischemia affecting the small bowel. Most infections that require debridement need to be dealt with rapidly. Necrotizing soft tissue infections are a surgical emergency, as is ischemic or gangrenous bowel. The one exception to this rule is necrotic tissue arising in association with infected pancreatic necrosis. And the reason for this is it tends to be relatively walled off in the retroperitoneum, number one, and that efforts to debride early are inevitably associated with very significant bleeding, which in itself can become life-threatening. So pancreatic abscesses are really the exception to the rule that I've been trying to establish here. There are some very nice options that have been developed recently that involve early drainage, percutaneous drainage, to decompress the liquid component of the pancreatic abscess, followed by delayed, minimally invasive approaches to remove the infected necrotic tissue. Now, the third element of source control is device removal, and that is the removal of any device that might have become colonized. It's striking that the infections that arise in critically ill patients are typically caused by microorganisms that have a predilection to grow in biofilms. They colonize prosthetic surfaces like vascular catheters or endotracheal tubes, and they're able to survive, persist in these environments, and they're also removed from exposure to antibiotics. And so it is very difficult to eradicate these infections purely with the use of antibiotics. Now, obviously, it depends on what the device is that's infected as to how aggressive one wants to be with source control. If it's an infected Foley catheter, then it is a simple matter to replace the Foley catheter. And in most cases of catheter-related urinary tract infections, there really isn't a role for systemic antibiotics. Central lines similarly can usually be replaced, although sometimes access can be a challenge. A prosthetic joint or a heart valve involves significantly more risk to the patient, and it's for that reason that we typically treat endocarditis with antibiotics before considering options for source control. So this is a fairly rapid overview, and I'm trying to focus on the principles here of source control, the principles being draining any component of infection that is liquid and localized, debriding any component of infection that involves necrotic tissue, and removing any devices that have become colonized, typically Foley catheters, intravenous lines, and potentially endotracheal tubes, although that has not become a standard part of the management of ventilator-associated pneumonia. I won't go into the details of definitive repair, as that falls more exclusively in the realm of surgery. Timing, it should be as rapid as feasible, particularly if necrosis is present, but there are very few data available on optimal timing of source control. I think as a general principle, though, early source control is important. Now, one of the important concepts of source control is that it is in many cases, an alternative to antibiotics, and successful source control can actually minimize exposure to antibiotics. This was the very nice study looking at the duration of antimicrobial therapy for intra-abdominal infection led by Rob Sawyer. And one of the things that I think is particularly important in this is that, first of all, there's no difference in outcomes between a short course and a long course of antibiotics if source control is efficacious. No difference in secondary infections such as surgical site infections, but a significantly more rapid diagnosis of those infections in patients who have a shorter duration of antibiotics. So just to summarize, it's important in any patient with sepsis to consider opportunities for source control, undertake these as rapidly as feasible, reevaluate the adequacy of source control when sepsis fails to resolve, think about this rather than an antibiotic failure, and engage surgical expertise in decision-making. Although the modalities for source control are widely available, a lot of the thought processes still sort of fall in the area of surgery, and I think this is an area where collaboration among specialties is really important. Thanks very much, and I'd be happy to take any questions you might have.
Thank you, John. There was one question particularly around very critically ill patients, patients in shock with an obvious source of intra-abdominal sepsis and the risks of taking those patients to the operating room.
I think it depends on what the source of the sepsis is. If it is ischemic bowel, one really has to simultaneously resuscitate and resect, because that's only going to get worse at the longer that one delays. If it's a patient with peritonitis, then I think secondary, for example, to perforated peptic ulcer, perforated diverticulitis, then I think it's more appropriate to focus on administering antibiotics, trying to stabilize the patient as much as possible before the patient goes to the operating room. So it really is tissue necrosis within the abdomen. The necrotic bowel really is a surgical emergency. Pus within the abdomen, less so.
I wonder if you've got any thoughts about the vacuum systems that have been coming out and their ability to control. I was thinking particularly about your open abdomens and adding a vacuum system to those when you've had an intra-abdominal contamination.
There's certainly a significant advance in managing patients primarily from a nursing perspective. It's easier to maintain an open abdomen with a vacuum type system as a dressing. It facilitates re-exploration if that's necessary. It's associated with a lower risk of fistula formation and other complications. And it does seem to, in the longer term, expedite wound contraction and granulation. So all of those things really simplify the process of nursing care in the intensive care unit and ultimately the recovery of the patient once they've been discharged from the ICU.
And then one final question, that ultimate decision between local dissection of a necrotizing limb versus the decision to amputate.
I think the critical factor there is there muscle involvement. In necrotizing fasciitis, typically it is the skin and subcutaneous fat that's involved and the muscle is intact. And so I think you want to assess the viability of the muscle. If the muscle is necrotic, I think then amputation becomes necessary. But I think it's equally true that there are a number of unnecessary limb amputations for patients who could be managed simply by adequate surgical debridement of skin and subcutaneous fatty tissue. So think about function as being the determining factor in that, and that function is the viability of the muscle.
Thank you, John. It's time to move on to our final speaker of this session. So our final speaker is Professor Arjun Dondorp, who is a professor of internal medicine, infectious diseases, and critical care in Bangkok at Mahidol University, who's going to speak about choosing the right antimicrobials in our resource-limited settings.
Yeah, thank you very much for your introduction and welcome everybody online. So this will just be a brief presentation to highlight some aspects, specific aspects of treating patients with antibiotics in resource-poor settings, which will also frequently be tropical settings. And the topics I will cover is something about availability of antibiotics, specific causes of sepsis that we see in the tropical world that are not covered by the usual empirical treatments, something about antibiotic resistance patterns, which are a bigger problem in resource-poor settings than in Western countries, and then highlight the importance of development of local guidelines for your local hospital where you work. So the next slide is about excess versus excess of antibiotics. So developing countries are often blamed for overuse of antibiotics, and that is true in a way because antibiotics are usually can be bought over the counter, are used for every fever there is. But at the same time, because of poverty, there are large populations that do not have access to antibiotics, and you can see that in this slide, where on the y-axis you see the number of patients of under 5 years old per 100,000 population that die per year from pneumonia with the organisms you see there. And on the x-axis, the number of those patients that have access to antibiotics. And you see, for instance, India is a big circle there where access to antibiotics is still a huge problem, and you see many other countries in the developing world with very low proportion of patients with access to antibiotics. So there's both an access and an excess problem with antibiotics. Then highlight some of the causes of sepsis and severe sepsis that we see in the tropics that are not covered by the usual empirical treatment. Depends very much where in the tropical world you are. So I mainly work in Southeast Asia, and here sepsis is often caused by a soil-dwelling bacteria, Burkholderia pseudomeli, and in northeastern Thailand, 20% of all sepsis is caused by this bacterium. And it's not covered by third generation cephalosporins or gentamicin, so you have to give ceftazidime or carbapenem. Sorry for the spelling mistake there. So you have to know then in your local hospital that this is a common source of sepsis. And another example is on the right-hand side. This is more in northern Thailand and in Laos, where severe febrile illness and sepsis is often caused by scrub typhus, Orienta tsutsukamushi, and also leptospirosis and dengue, and murine typhus is very common. So scrub typhus is another example, not covered by third generation cephalosporin, but is doxycycline responsive. So you have to know your local epidemiology. And of course, if you're in the tropics, you also have the real tropical diseases. Malaria always has to be excluded when a patient comes in with a sepsis syndrome. In Africa, there will be mainly children. In Southeast Asia and South America, although there's less malaria, can be all age groups. And of course, then you need to give a parenteral antimalarial. So artesunate is the first line there. And then dengue, severe dengue and dengue shock, also common in tropical countries. It's spreading through the tropical world, but also more and more in the subtropics because the vector of the disease, so Aedes aegypti and Aedes albopictus, is spreading ever further. Also there, of course, it's not treated with antibiotics, but also other aspects of treatment like fluid management will be different in severe dengue compared to bacterial sepsis. If you do large surveys on the causes of sepsis, and here as an example, a large study we did in Indonesia, Thailand and Vietnam, doing blood cultures in all severe infections that were admitted to the hospital, you see a lot of common pathogens also growing. Nevertheless, I highlighted some of the less usual pathogens that come up. As I showed in my last slide, Orienta tsutsukamushi, which is scrub typhus, leptospirosis. In cause of meningitis, especially in Vietnam, is Streptococcus suis. It's a big disease that can easily be transferred to humans. So again, it highlights that you have to know your local epidemiology. You also see in this slide that a lot of the blood cultures are negative, and that has to do that almost all patients before they arrive in hospital, they have often had some antibiotic bought over the counter. And then there's the huge problem of antimalarial drug resistance. Here you see, just to illustrate the different antibiotic groups that have become available over the years, and then the years where resistance to those same antibiotics have emerged. So we see all the common well-known examples. ESBL, so extended spectrum beta-lactamase, producing Enterobacteriaceae. Huge problem in the tropical world, especially also in South and Southeast Asia, with now numbers of E. coli and Klebsiella pneumoniae resistant bacteria, over 80% in India and 60% and even more in China in hospitalized patients. The KPC and NDM1 carbamazepinases, also a huge problem. I'll show that in the next slides. MRSA, colistin, more recently, fluoroquinolones, even linezolid resistance. It's all here, and it's only increasing. And to illustrate that, a few examples, just to briefly mention it. So non-typhoid salmonella in Africa, fluoroquinolone resistance is increasing there. Same for Salmonella typhi, very common cause of sepsis in Nepal, for instance, and parts of India. Big problem with fluoroquinolone resistance, not really useful there anymore. And then on the right side, you see the carbamazepinase producing enterobacteriaceae. Huge problem in India, especially around 8% now in hospitalized patients, but already quickly increasing further. And it's not, let me see, the next example is not from Asia, but from Africa. Similar problem, maybe a little bit better there. These are ASBL producing gram-negatives. You can see clearly that that is increasing over the years, as is resistance to ciprofloxacin and gentamicin. So just to say, antimicrobial drug resistance is even a bigger problem here than in the developing world. This last slide that you see now is MRSA, which, by the way, did not start in the developing world. Also a huge problem, especially in the hospital-acquired settings. So you have to know somehow your local resistance patterns. And there's the problem that most hospitals, or a lot of hospitals, do not have adequate microbiological labs. So you will have to rely on sentinel sites, hopefully in the neighborhood of your hospital, where you get that information, what the resistance patterns are. Lots of initiatives to try to curb this ever-increasing antimicrobial resistance. But in all those guidelines, you have to realize what the situation on the ground is in poor countries. Here's some pictures from hospitals we work in Bangladesh and India. Patients often on the ground. You can see on the left upper hand photograph, it's very difficult to work clean in an environment like that. Running water not always available. Infection prevention often focuses on wrong things. So I here have a picture of these overshoes that are not very useful. As I said, microbiology support is mostly not available. Possibility for patient isolation also usually not there. And then there's the problem of where to buy your antibiotics. Often you get a prescription, and the family of the patient have to go themselves to the drugstore to buy the antibiotics. They often have to pay for it themselves, so they tend to buy as few doses as possible. And also, drug quality is a problem. Further, of course, having a negative impact on patient outcome, but also on drug resistance. It's very important, as I said before, that hospitals make their local guideline. You cannot depend on guidelines from Western settings for all the reasons I mentioned before. The causes of sepsis can be different. And the antibiotic resistance patterns can be very different from Western settings. So this slide I won't comment on in any detail, but just to say that together with local doctors in a hospital in Workla in India, we made a local guideline for antibiotic use, which was a huge improvement how antibiotics were used there. The fact that you have to start as quick as possible, preferably within 1 hour when a septic patient comes in. Those studies are from Western settings, but they are generalizable to resource-poor settings because that is something that is implementable. We have tried that ourselves also in the resource-poor settings. Then my concluding slides, just concluding, summarizing what I've told you in the previous 15 minutes. So key elements for choosing the right antimicrobials is that you have to have a locally adapted guideline based on the local epidemiology, because the cause of sepsis can be tropical diseases, malaria, dengue, rickettsial diseases, melioidosis as an example. And resistance patterns can be very different and are a big problem. If possible, take blood cultures or other cultures before you start the treatment. Often that will not be feasible because of the lack of microbiological labs. Also, the yield in places where we do it is disappointing because of pre-treatment at the peripheral level by over-the-counter antibiotics. So the yield is often 5% only. Start quickly, which is sort of self-explanatory, and know when to de-escalate, change the antibiotic regimen, or stop the antibiotics. And it's not only antibiotics, of course. You have to think of when you treat a septic patient, there should be source control, as discussed by John Marshall, and implementation of infection prevention and control practices, even in settings where this is difficult, is very important to curb this ever-increasing problem of antibiotic resistance. So thank you very much for your attention.
Thank you very much, Professor Dondorp. I'm going to ask one question. It sounds, we're hearing about the implementation of new antimicrobials coming down the pathline, but it sounds to me as if we need to really focus on some of those tropical pathogens because their resistance patterns are very different than the typical gram-positive, gram-negatives that we might see in the developed nations.
Yeah, I think that is true. We always lack studies in resource-poor settings, so we are often uninformed. But when you do a study, that can give a lot of information on what is important to specifically develop in these countries.
It also sounds like that there is one question around what to do when faced with a source of sepsis not clear and the non-identified culture or the culture negative patient in the developing world. But it sounds like you struggle with the same problems we do, broad spectrum that has a high propensity for developing antimicrobial resistance to other pathogens.
Yeah, it's true. And here we are confronted much more often that there is a shot in the dark and there will not be cultures available after a few days. So when to switch, when to de-escalate, when to stop is much more difficult often to do in our settings here.
Thank you very much, Professor Dondorp. I want to thank all of our speakers at this time and thank our sponsors particularly. I'm going to remind our audience that to look for the newsletters that are coming up and to continue to ask your questions. If you or your community has not signed the World Sepsis Declaration and received the World Sepsis Day newsletter, please do so. So all news about sepsis and what's happening around the world. There's an active Twitter feed, I'll tell you as well. And look forward to hearing about World Sepsis Day events on September 13th. And again, thank you to the audience and thanks again to all our speakers.